Good afternoon, everyone, and welcome to this webinar on health homes for children with serious behavioral health challenges, examples using evidence-informed wraparound approaches. This webinar is sponsored by the Technical Assistance Network for Children's Behavioral Health and Human Service Collaborative, where I am. This is Sheila Pyries. I'm with Human Service Collaborative, and we are a core partner of the National Technical Assistance Network. And the network is funded by the Federal Substance Abuse and Mental Health Services Administration. We are very happy to have with us today representatives from 2 states who are implementing health homes for this population of children, building on what we know works. And that is Elizabeth Manley, who is the Assistant Commissioner of the Division of the Children's System of Care in the New Jersey Department of Children and Families, and Jackie Shipp, who is the Director of Community-Based Services for the Oklahoma Department of Mental Health and Substance Abuse Services. What we're going to do is I'm going to provide you an overview of health homes and that provision in the Affordable Care Act and how those provisions translate to children with behavioral health challenges. And then Liz and Jackie will talk about how they are implementing health homes in their respective states. So health home basics. Health homes are a state plan option that were created under the Affordable Care Act. The overall goal is to improve integration across physical, behavioral health, and long-term services and supports. It also provides an opportunity to pay for what have historically been difficult to reimburse services, such as wellness supports, provides flexibility for states to develop approaches that address their broader goals of improving quality and the cost of care. And states receive an enhanced 90% federal match for the first 8 fiscal quarters of the health home benefit. So there's also an incentive financially to implement health homes. States have the opportunity to identify health home populations by health condition. A number of those are specified in the Act itself and with regulations that were promulgated by the Centers for Medicare and Medicaid Services. And also populations can be identified by geography, so health homes do not have to be statewide. But you cannot identify populations by age. So if you're implementing a health home, for example, for persons with serious mental illness, which is one of the populations specified in the Act, you cannot only do health homes for adults or only health homes for children. You must do both. But you can customize the approaches for each. So who can receive services? Populations with 2 or more chronic conditions, those with 1 chronic condition and a risk of a second, and persons with serious mental illness, again, both adults and children. I should also mention that we have at least 1 state, which is New York, which is negotiating with the Centers for Medicare and Medicaid Services for their health home for children with serious emotional challenges, to use trauma as also a defining clinical condition in order to also focus on their population of children in foster care. So that's something that we're also paying attention to. What are health home services? They include these in the box, which are a little difficult to read, I see. Comprehensive care management, care coordination, health promotion, comprehensive transitional supports, individual and family support, and referral to community and social supports. So what does that mean when it comes to children? What we're doing here is trying to translate these terms. So comprehensive care management, think about how you're going to identify, screen, and assess children who would be appropriate for the health home. How are you outreaching to and engaging youth and families, eligible youth and families, the mobilization of child and family teams, because if you're taking an intensive care coordination approach using Fidelity Wraparound, which is what the two presenters will be talking about. That uses a child and family team approach. Development and updating of a coordinated plan of care, so continued mobilization of the child and family team to update the plans, and monitoring clinical and functional status. Care coordination and health promotion, and sometimes when people are developing their health home applications, they're struggling with, well, how do we differentiate between comprehensive care management and care coordination? So think of care coordination as actually the care coordination done by, in the examples we're using, the Wraparound Care Coordinator, so ensuring that youth and families are able to get to services, that they make and keep appointments, that they're moving along and trying to achieve the goals in their plans of care, facilitating linkages for them to services, ensuring communication across providers and with other systems like the schools and the courts, and all of that can be included under care coordination. Then when we move to comprehensive transitional care from inpatient to other settings, including appropriate follow-up, obviously with children we're also talking about other out-of-home treatment settings, in particular residential treatment. Individual and family supports. In the world of children's behavioral health care, we are usually talking about family and youth peer support and system navigation that's performed by families and youth with lived experience. And there are, of course, many states that are now covering family and youth peer support under Medicaid in one way or another. Linkage to social supports and community resources, and making sure that those are those that are relevant to child and youth populations. And then health promotion and wellness, and both Jackie and Liz will talk about how they've integrated wellness approaches into their health home approaches using Wraparound. I want to point out that health homes are different from medical homes, that all children can benefit from medical homes, that typically medical homes are trying to coordinate medical care, also linkage with behavioral health, but they're typically built on physician-led primary care practices. Health homes are designed for populations with chronic conditions, and so it's a subset of all children, and are coordinating physical, behavioral health, and social supports, as I just discussed. And they don't have to be built on primary care practices, for example. It could be a behavioral health specialty home, as Oklahoma is doing, building on its community mental health centers, or it could be a private nonprofit organization that is customized to provide care coordination for children, which is what New Jersey is doing. I want to point out that children who use behavioral health care in Medicaid are an expensive population. Their costs tend to run nearly 5 times higher than Medicaid children who do not use behavioral health care. And if you disaggregate that population by aid category, the foster care population, for example, is nearly 7 times higher, and children who qualify for supplemental security income or state disability criteria, their costs run nearly 9 times higher. And their costs tend to be driven by behavioral health care, not by physical health use so much. That's very different from adult populations with serious mental illness, where their costs tend to be driven more by physical health care use because of comorbid physical health conditions. Children who use mental health services and substance use services in Medicaid are not as healthy as Medicaid children in general, and Medicaid children in general are not as healthy as children in general. But even saying that the comorbidity of having a chronic physical health condition, those rates are not nearly as high as with the adult population. And if there is a chronic health condition, it tends to be something like asthma. You know, it's not heart disease or chronic obstructive pulmonary disease or, you know, some of the more high-end, expensive conditions that you see in the adult population. Children are also different from the adult population in that their diagnoses are different, tend to be different from adults. and their diagnoses change over time. And also, children with serious behavioral health challenges, who are, for the most part, the populations being focused on for health homes, 2/3 of them typically are also involved with other systems that have legal mandates for children, so child welfare, juvenile justice, the schools. And so, it's very, very difficult to develop effective, comprehensive, coordinated plans of care for children without taking into account what's going on in those other systems that's affecting children. And then coordination also is important, not only across those systems, but it's even thinking about evidence-based approaches. They're all home and community-based, and you have to work with the entire family. And so this, the degree of coordination needed, the schools, the courts, other systems, the extent of the family work that's involved with caregivers, with parents, with other siblings, has implications for the intensity of care coordination that's provided and the cost of that care coordination. Okay. States that are drawing on evidence-informed practices are either using what we call care management entity approaches, which are organizations whose role it is to provide specialty care coordination for these populations of children, which Liz will talk about in New Jersey, or they're embedding high-quality wraparound teams into supportive organizations like a community mental health clinic. It could be a school, it could be another agency. In Oklahoma, we'll talk about how they're doing that with their community mental health centers. This approach also, an intensive care coordination wraparound approach as the platform for a health home care coordination, also integrates parent and youth peer support services as we talk about them in the children's world. And there is a long history of developing parent and youth peer support capacity provided by parents and youth with lived experience. Both intensive care coordination using wraparound and family and youth peer support were included in the May 2013 joint bulletin that was issued by the Substance Abuse and Mental Health Services Administration and the Centers for Medicare and Medicaid Services, providing guidance to state Medicaid directors on what services and supports should be in place for children with behavioral health challenges in Medicaid. The other thing I would point out is that this approach, an intensive care coordination wraparound approach, lends itself to coordination with primary care, because the wraparound provider or team can be charged with ensuring that the child has an identified primary care provider, that early periodic screening, diagnosis, and treatment, EPSDT screens, are happening on schedule, that the child receives an annual well-child visit, that if the child is on psychotropic medications, that the primary care practitioner is doing metabolic screens, because we know the child will be at risk for issues such as diabetes and obesity, and ensuring that that primary care provider has the plan of care, is informed that the child is involved in the health home. All of those are critical. The American Academy of Pediatrics, in some studies that they have done, have noted that there is a high unmet need for care coordination for children and youth with mental health conditions, and that family-centered care can be mitigating. And that's the fact that New Jersey and Oklahoma have customized their health home approaches to provide a higher level of care coordination for children, and that it's built on a wraparound, which is a family-centered approach. It helps to counteract the issue we have sort of nationally of this high unmet need for appropriate care coordination. And we also have a kind of unmet need for appropriate approaches, or customized approaches, as I would say. I mean, neither traditional case management nor the care coordination performed by managed care organizations, for example, and many states are moving their behavioral health dollars into capitated managed care environments in which the managed care company has a care coordination role. That type of care coordination, which is telephonic and is over large numbers of people, is not really, it's not going to get us where we need with children who have intensive behavioral health needs or are at high risk for developing serious behavioral health challenges. And neither are the approaches for adults. And so I talked earlier about the need for lower case ratios. In a wraparound, fidelity wraparound approach, the ratios look more like 1 to 10, one care coordinator to 10 children. You know, if you've blended and you're including an at-risk population, it might be a little bit higher, as New Jersey has, but still probably not going to be any higher than 1 to 14 or so. And in health home approaches for adults, the case ratios tend to be much higher. I gave the Missouri example of 1 to 250, for example. There are also higher payment rates needed. We've done a scan through the Center for Healthcare Strategies of what states are paying in terms of bundled care coordination rates, just covering care coordination costs for children using a wraparound approach, and they range from about $780 per member per month to about around $1,300 per child per month at the higher end, but they average about $1,000 per child per month. And again, that's very different from the rates you tend to see for adult health home populations, which are, you know, at least half that, if not less. So I wanted to just say there also has been some work done by Center for Healthcare Strategies looking at pulling together lessons from health home demonstrations serving a variety of adult populations, not just those with serious mental illness. And again, this is just looking at what we know from serving adults. But there's resonance around you know, designing and implementing health homes for children. The various states that were involved in this kind of lessons learned discussion with Center for Healthcare Strategies noted that you really have to establish a much closer connection from the outset between the organizations responsible for care coordination and provider organizations that are delivering the services needed. And that also includes primary care providers. That the data sharing issues and needs, you know, are critical. That you have to ensure reimbursement for locating and enrolling high-risk, high-cost enrollees. You don't want your health homes underutilized. That there's extensive education needed to build relationships with other organizations. For example, in our case, it would be with, you know, with the courts, with child welfare, juvenile justice, with the schools, and building consistent communication mechanisms, because health homes are an aspect of system reform, so there's something new, you know, about them that you need to constantly kind of be communicating about. And most importantly, and this is something that we've learned in the children's behavioral health arena, in the system of care world, that you can't underestimate the importance of ongoing workforce training and coaching. And that was an issue that came up kind of repeatedly even around these adult demonstrations. I'll say one other thing, which is that states can submit one health home state plan amendment for persons with serious mental illness in which they customize for adults and for children, which is essentially what New Jersey and Oklahoma did. Or they can submit two separate health home state plan amendments, one for adults and one for children, but they have to have the same effective date, or at least I would say that the clock starts running on the 90% match on the date whichever one starts, so you want them on the same effective date. And that health home services can't duplicate those of other management entities. So in an age where we have managed care coordination, we have maybe targeted case management going on in child welfare and juvenile justice and other systems, where there may be accountable care organizations, there may be patient-centered medical homes, all charged with doing various types of care coordination. in your application to the Centers for Medicare and Medicaid Services, you have to make it clear that you're not duplicating care coordination functions. And so it helps to sort of develop matrices that line up what's the differences across them, so you can answer that question because you are guaranteed to get that question. Okay, I'm going to stop with the overview, and now I'm going to turn for a moment I'm going to turn to New Jersey. Liz, we created this schematic of the New Jersey system of care. If you care to use it and kind of give people a basic sense of how you're structured, and then you can talk about your health homes and how they fit.
Sounds good. So New Jersey's children's system of care is a system of care that's been in existence here in New Jersey for about 15 years. We're celebrating our 15-year anniversary, and with that, this chart actually is a pretty good depiction of what the children's system of care in New Jersey looks like, with an overview being that we have the state component, or the New Jersey system of care, sets the vision for services, sets the policy, and oversees the workforce, the provider pools for all of our partners in New Jersey. We have a contracted systems administrator right now as Perform Care. Perform Care's role is to be the single point of access that all parents can call to access services and supports. They also do screening, utilization, management, and they have a very big role in the back door in terms of ensuring that both providers are paid and paid appropriately for the services that they determine. They have both the clinical oversight of all the plans of care for youth and ensuring payment happens. We have 15 family support organizations, which are nonprofit organizations that are partners with this work. And we're going to focus some attention on care management organizations today because they play a very big role in the behavioral health home world. But I do want to just say that we also have mobile response and stabilization and a training contract, which is incredibly important for all of our work here in New Jersey. The behavioral health home conversation started here in New Jersey in really October 2012, just like pretty much all other things. But basically, the discussion was started because our adult partners were really looking to really begin the process of going through a state plan amendment process and recognize that the children would really need to be a part of the conversation. And we're very pleased that we were part of that discussion. And with that, there was a lot of emphasis on the adult world, which happens quite a bit, I think, for many states. But for us, it gave us the opportunity to really think about what we wanted a behavioral health home to look like. We do call it a behavioral health home here in New Jersey because it helps folks to understand that we have embedded the behavioral health home into the behavioral health system, specifically into the care management organizations. And we did that for a lot of the reasons that Sheila's already talked about, because we already had a plan and we were already embedded in the communities for the care management organizations. So we see the behavioral health home component as an extension of the child family team. By putting the medical expertise around the table, we're really able to coordinate care in a way that we hadn't been able to do before. I often have to say that behavioral health home is not a home, it's not a house, it's not a facility, but it's the idea of bridging care between what's going on for a youth with a chronic medical condition and that medical condition and what's happening for them in terms of their challenges or concerns around their behavioral health challenges. So it's really developing a clear plan of care that makes sense. One of the other reasons New Jersey has decided to embed our behavioral health home in the behavioral health system really has to do with the fact that most of our children here in New Jersey already had a pediatrician and were connected to a pediatrician for their primary care. And we did not want to disrupt that relationship, but we wanted to really utilize that relationship to ensure that the chronic medical condition and the behavioral health challenge were really addressed in one single plan. And the way recognized the best way to do that was to actually put a nurse at the table, at the child family team table, to help coordinate the care by being the conduit between the care management component that was taking place and the pediatrician or the primary care physician that was really treating the youth in their chronic condition. The care management organizations, or the CMOs, are agencies that provide care coordination within the context of Wraparound here in New Jersey. There are 15 of them, and they cover all 21 counties. All families have access as long as they meet the clinical criteria for care. But our behavioral health home is specifically designed for youth with a chronic medical condition who have Medicaid. So there is some nuances to the work that we really needed to work on. The care management entities work within the context of child family teams, which is really important because it allows us to develop individualized care plans for those youth. And they're responsible for facilitating the full plan. So that means that they really need to take away any barriers to care and to ensure that treatment is provided in the way that it needs to be. The children's system of care objectives are to keep our children at home, to keep them in their own schools and in their own communities, and this is the behavioral health home just allows us to be even more focused on that work, for sure. The care management entity as a health home is really important from our perspective, that we provided really the guidance to the CMOs around this. And I should say the CMOs, we have actually 5 of our 21 counties are currently have access to behavioral health home services, and the state plan amendments have been approved in all 5 of those counties for us thus far. We're working on the next 4. So the structure of the behavioral health home team is the core CMO, so the core staffing. So the way that we conceptualize that is the team, as it's conceptualized on the behavioral health side, stays intact. The care manager who's assigned is still the facilitator of the plan, the facilitator of the child family team. They are responsible for writing the care plan for the behavioral health side, and that we really just add the services and supports of both a nurse and a wellness coach for each one of those children who are engaged in the behavioral health home component. The nurse manager is required to be credentialed in New Jersey at a minimum of a registered nurse, and we have some folks who are have some other certifications and credentials as well. And the health and wellness educator needs to be a bachelor's level in a related field. We also have folks who have higher education as well. We have some nutritionists who have signed up to do this work, so it's been a really powerful experience for us. The care management entity as a health home, that core team is built on the CMO's array of staff with the intent to provide a holistic approach. We really believe that we were already putting the folks around the table in the wraparound approach that could address the behavioral health challenge. But we really needed to connect to the medical community that was providing the care. This expanded team did and has made a substantial difference in terms of being able to address that child's needs. And there's other screening now that takes place for our youth that did not take place before the addition of the behavioral health home. That is really facilitated by the nurse and the wellness coach. And we've added or expanded out our medical record, our electronic record, which we call cyber, to have a whole behavioral health component, behavioral health home component, in which we can document the care of that youth, which has really been pretty powerful. The health and wellness activities really include not only the youth but the family as well. So it could, just as an example, a youth with diabetes can have a nurse working with a pediatrician and providing an overview of what's going on for that youth. But the nurse and the wellness coach actually provide specific education to the parent. And the wellness coach actually could be in the home reviewing the nutritional plan. They can shop with parents. They can shop with youth. They can help them build a garden. I mean, there's a lot of really creative things that can happen when you put both a nurse and a wellness coach into the discussion around the chronic medical condition that has brought that youth into the behavioral health home in the first place. The other component that's really important from our perspective is that we have the family support organizations that also partner with the CMOs. So that family connection component means that our FSOs are sitting at the child family teams with the nurse and the wellness coach in these conversations, and it's really been powerful in terms of the change in how organizations perceive that youth and that family as one person, which is really quite powerful. The relationships with providers and the connections with schools have been also really important. And the idea that we're moving with our adult partners allows us to engage our hospitals, all of the medical community in a very different conversation at the same time. And so there's a lot of movement in the communities in which the behavioral health homes have been in existence. So it's been really great to watch. The qualifying criteria for our children must be, they must meet the medical necessity criteria for a behavioral health home, which we work with our Medicaid partners with to ensure that it met all of the criteria. But the children must be eligible for CMO. So we look at the behavioral health component first. They either, we actually added a DD component and substance use component into our state plan amendment because we're an integrated system of care that really provides supports and services to those populations as well. So that was an important component for us. The chronic medical condition includes asthma, diabetes, obesity, eating disorders, which we thought was incredibly important in underserved population within New Jersey, and one that, because of the complexity of the medical components, we've really struggled to be able to meet the needs of those youth, has been really important. We did include certain organic developmental disabilities because of the medical pieces and the costs of those to deliver those services. Substance use, cystic fibrosis, sickle cell, kidney disease, hypertension. These are the conditions in which we recognized we really had a need to address the needs for these particular youth from the start. We do believe that engaging our families in this wellness discussion is incredibly important and has really changed the way that our care managers view their work, which was a little bit of a surprise for us here. But we have always utilized motivational interviewing, but we have pumped up the training for all of our partners in terms of motivational interviewing training and supports around utilizing motivational interviewing to get families at the table. So it's been really important for us. And the whole focus on whole health has been really important as well. And not only did we see changes in terms of the care for the youth that were being served within the context of the behavioral health home, we actually saw some changes in the health of the staff who were providing the care and the services as they became more attentive to the needs of the children. They also became attentive to the needs of parents and children and themselves. So it was something we didn't expect, but it's been kind of fun to watch. So we know that everyone on the team pays attention to the body-mind connection. We are providing more support for youth to just engage in things like yoga and exercise. So that's important for us. And we're looking for the interconnections between asthma and anxiety, which has been really interesting for us to see those connections, and diabetes and depression. Our first behavioral health home, the first one that went live, really saw those connections pretty quickly, which was really interesting from our perspective. And we use skills we have in the behavioral health planning to support the family management, and that's been really helpful. The engagement of parents in this discussion has been very, very powerful, and it's been helpful for the full family. So the downstream work of the health home is really paramount, and wellness is everyone's work is really some of the things that have come out of the work around the behavioral health home components. So we have built a wellness program. Most of our behavioral health homes are up and running with wellness coaches. They are ensuring that our youth are engaged in daily exercise, and they look at nutrition and food intake. They maintain a healthy BMI, which they actually track, and that we're really working with our youth around smoking, drinking alcohol, and using drugs. And for us, we've done a lot of work around the smoking cessation component, which was really something that we needed to be attentive to, but we've become much more attentive to as well. And the issue of drinking and use of other drugs, since we're the substance use organization for the state, it was incredibly important for us to engage in those conversations as well. So other examples, so we have built family-based intervention in supports. We had a lot of them already, but how do you bring folks into the different part of the conversation when you're really trying to address a youth who has a major anxiety disorder, and you're looking at their full wellness, and health has really been powerful for us in terms of how we have accomplished some of our goals. We've done a ton of different work around making sure that our youth are moving and getting off the sofa and walking and exercising. We've seen, and just as an example in this area, we had one of the first youth engaged in the behavioral health home was a 15-year-old girl who was really struggling with diabetes, and her diabetes was pretty well out of control. But she connected pretty quickly to the wellness coach, who got her really interested in exercise. And so she started, she lived in a group home here in New Jersey, and she not only started to exercise herself, but she got the 4 other residents within the program working to exercise with her, first by walking and then by running. And so really it's been very, very powerful. We've had our youth engaged in all kinds of activities around wellness and support. And one of our health homes, behavioral health homes, has a community garden, which has been really also very powerful for not only for the youth engaged in the behavioral health home, but for the community itself. So these are some of our expected outcomes, include improving health, promoting better functional outcomes. We're already beginning to see that in the 5 communities in which we have the health homes up and running. Decreasing the cost associated with the use of acute medical care. We're seeing that, and what's interesting and we didn't expect is we're not just seeing it on the medical side of a youth not going to the emergency room because of their diabetes, but we're also seeing that the stability around a youth and their diabetes has kept them out of residential care. We've seen that at least on 3 occasions in 3 different places, because we've been able to work to stabilize the diabetes. The other components that we're pushing towards out-of-home treatment really subsided, and the youth, those 3 youths in particular are doing quite well now. We did have a behavioral health learning community, because we do believe that teaching, collaborating, exchanging, and learning is really important. So every rollout of the behavioral health home is a learning community, not just for us on the children's side, but on the adult side as well. It has helped really engaging communities in this whole conversation and been a big part of the rollout for us here in New Jersey. And then the enrollment process for us is we try to make it as really relatively easy and simple as possible. It allows for 2 points of access. The contracted systems administrator or Perform Care can actually screen and does screen up front for eligibility. They sometimes don't have enough information on the medical component. So the care management organization, when they identify that there's a youth who has a chronic medical condition, can also be the point of access to open up behavioral health home services for our youth and families as well. And the statewide rollout, basically we opened behavioral health home first in Bergen County, and then in Mercer County, and then we've just finished Cape May, Atlantic, and Monmouth. For those of you who know New Jersey, that means that we're both in the north, central, and the south of New Jersey. because we're very, very interested to see how it goes in different types of communities. And we're working on 4 new communities, hopefully, to roll out within the next budget year. That's New Jersey.
Thanks very much, Liz. That was very informative. And I think it's interesting how New Jersey built on an infrastructure that they developed through your various system of care reforms over the years, and particularly your care management organizations that are your specialty care coordination entities, as your, to build on them for your health homes. So now we're going to shift to Oklahoma and to Jackie Shipp. And Jackie, again, we just created a little schematic to show how you are embedding your wraparound team as a health team, in effect, within your community mental health center, and you took a sort of customized approach for adults and then a different customized approach for children. So I'll turn it over to you now.
All right, thank you. I was just very inspired by Liz's presentation and also struck by a lot of similarities in our development and in our philosophy between our 2 states, which is interesting, being very diverse states from each other in geographic location and culture, probably. That's interesting. So I want to talk about SuniCare Health Homes, and actually in our state plan amendment, ours are behavioral health homes, but early on we started branding and talking about health homes because we really needed to help our providers get the concept that they're now responsible for overall health. They are the entity responsible for the overall health of their adults with SMI and children with SED, and they don't have to do all the health care, of course, but they are ultimately responsible that it happens, and it happens in an efficient and timely way that takes care of the health of the people that they serve. And I think at some point we'll probably rebrand as behavioral health homes, but I think that was important in the beginning for us. So I'm not going to talk much about the adult health home state plan amendment. I'm going to focus on the children today, but these slides will have some information about both, and I would be glad to discuss. I've been a part of the core health home team from the beginning. I can discuss either one with folks and help them understand what our thinking was and what we've done. We began the initial dialogue a long time ago, and we hit a lot of snags, which hopefully I'd like to think may smooth the way for other states coming in, because CMS really had a difficult time understanding our model, our wraparound model, and how that was going to be used, how different that was going to be from adult, and how the rate needed to be much higher. There were some other snags involved also in just the way that things are set up in Oklahoma and targeted case management with our being built child welfare and juvenile justice entities. But we stuck with it, and we kept up that dialogue, and with our commissioner hot on our heels saying that we should have been already doing this, and we were feeling very urgent to get it done the whole time. So what we ended up with, looking at, I don't know if you all are familiar with the 4-quadrant model. I don't have a slide for it here, but the philosophy is that since we chose one condition, and that is serious mental illness, knowing that is the condition that is most likely to cause a person significant difficulty functioning in the community, being able to have a job, being able to have a life in the community with a family, with transportation, with the education of their choice, and all of those things, that we just wanted to still focus on that condition. And that being said, we also wanted to be able to move upstream a little bit and help people developing that were not maybe meeting as high a criteria as we have for wraparound. And so actually for both adult and children, we developed a criteria for high intensity and moderate intensity within health home. And so for children, I'll go back to that other slide. I think there's a slide later on about the rates, but for children, the only criteria is the medical necessity criteria for serious emotional disturbance. Once that has been determined, that's all they need to be eligible for health home. We started with, and we still have 22 health home providers, and actually 15 of those are community mental health centers, and we've ended up with a handful that are not community mental health centers. And they have, I believe now, 137 locations among the 22 of them in the state of Oklahoma, and so we are statewide. It probably took a good 6 to 8 months before they had all those locations open. One very exciting thing that was new in our Oklahoma system of care is that we now have a choice of providers. So there's choice of wraparound provider in every area of the state except one small area. And so that's just another improvement that happened through our health home development. So in order for a child to be determined to be at the high level of health home, and that was really tricky in negotiating with CMS because of our rate, is that they also have to score significant clinical impairment on our Ohio scales. And that helped us, when CMS began to understand what that meant, it helped us to be able to get the rate we needed for wraparound. So moving on, this is very similar to what Liz shared, so I'm not going to belabor this very long, just to say that it's been absolutely awesome to be able to add the nurse to the team for children and add the wellness coach. And that's really the pieces, those two pieces have helped just broaden what the wraparound teams are able to see that can be done for children and families, and how important and integral the overall health is in the whole scheme of things. And again, also we've seen a big impact on the staff. On our staff, we actually have a wellness team here at our department funded by some tobacco settlement funds, and they work with all the providers on wellness initiatives as well, and and modeling what the providers can do, working with the youth and families on wellness initiatives. We have many that are using advanced practice registered nurses, and they're absolutely doing fantastic things out in the field. Lives, and there are so many stories that could be told, but I am just struck by one young man in northeast Oklahoma who, because of different medications and different issues in his life, was sadly obese at a very young age. I want to say he's 13 or 14, but he was seen early on by health home, and had a wellness coach and nurse working with him, and just began with walking, and that developed into running and having a plan for running, and learned that he just absolutely loves running. So then he's actually participating in the community on a running team, and I think he's lost like half of the weight that he had. He's lost way over 100 pounds. So those kind of stories are coming in from all over the state, and also just finding out through working with the health side, finding out all kinds of things that would not have come to light that could have been helped with otherwise. So going back, this is going to tell you our rates. The Children's Health Home High rate, again meeting the medical necessity criteria. which includes the clinical impairment. And we have a differential rate for urban and rural because it's more expensive to provide these types of processes. We have a very large state, and there's very large spaces between people out in rural Oklahoma. $1,009 per member per month in rural for Children's Health Home High. And along with that, we do expect an intensive service, and we do monitor for okay, when that says a team caseload, that's not talking about the wraparound team. That's talking about within a health home, how many they're going to have in one of those small health homes. So, actually, it's 1 to 10 is the case ratio per care coordinator, and that also includes a family support provider, because in our model in Oklahoma, the way we established and have continued is we just found that those teams are very well bonded when they're co-located and working together as a team continually. And so every family, unless they do not wish to have a family support provider, has one as part of their team. And so they're an integral part of everything that happens for that family. So moving on to the moderate, as you can see, the rates drop quite a bit, and the expectations are less. And again, those caseloads are not; those are for the entire health home. But I can show anybody that wants to see the individual requirements. I'll be happy to share them with anybody that would like to see those. Again, I think it's really important, and it helps to identify children still early in the stages of SED, because again, the earlier you can reach children with effective services, and the quicker you can get them on a better trajectory, the better the prognosis and the outlook for their life outcomes. And that's what we're all going for, is that children can grow up to be healthy adults who can be independent and can reach their goals in life. So when we selected our health homes through an RFP process that was very rigorous, we then also created our rules, promulgated the rules for behavioral health homes, and did a lot of readiness work. We also had a learning collaborative that went on. It's been going on for 2 years now in partnership with the University of Oklahoma School of Medical Informatics. We have a physician champion, Dr. Eric Vanderlip, who's been absolutely fantastic. He's board certified both as a child psychiatrist and as a family practitioner, so he's just been awesome in being able to bring both sides together. And I may take a minute here just to say one of the biggest challenges that the health homes have had has been connecting with the different PCPs, in particular the patient-centered medical homes in Oklahoma, and getting them to see the value of what they do and to see the value of consulting with them and taking some time for that, and also having a memorandums of understanding with them, because under our state plan amendment they need to do that. And it's been a slow process, but in the last few months we're seeing signs that there's really some breakthroughs and that they're beginning to make those connections that are going to be so important. There are a few health homes that are doing really wonderful providing medical services themselves. We allowed them to have different models. They can co-locate. They can have their own clinic if they would like to have that. That also gives people the choice. If they still have their PCP, that's fine. They'll still consult with them. But however they choose to do it, they're still responsible that it happens, that the care is integrated. So I think I'm going to, they also can be reimbursed an outreach and engagement fee of $53.98 a month, trying to engage a member into the services, only payable for 3 months in any year. We do require, and this was, we went back and forth, and because we're trying to take providers away, our ultimate goal, and we're also doing certified community behavioral health centers, is to move providers away from the fee-for-service 15-minute increments, and in thinking that way, and instead thinking, what does this family need on a given day? What is going to help this child and family? We're going to do what it takes, and we're not going to have to sit here and worry about what can we bill for, what we can get paid for today. We're going to get paid on outcomes. And Oklahoma is moving in that direction as fast as we can. But to ensure CMS, to ensure some of our state people that we weren't going to be letting these health homes run amok, we are at the current time still requiring the shadow reporting, and so they are entering information into our billing system, which is a joint billing system between our department and our state funds and Medicaid, in the Maya system, as if they are billing 15-minute increments when they're not. So I have a lot of mixed feelings about that, and we're going to be moving away from that at some point. Technical assistance and training, I agree, it's absolutely essential, and there will never be a time it won't be essential to keep it ongoing. We've also system of care, and with Wraparound, we'll continue to do that with Health Home and with CCBHC as we move into that. We have monthly TA sessions. We do calls and webinars as needed. We offer specialty training in the core things that are absolutely essential ongoing. The chronic care model, which Dr. Vanderlip is wonderful in explaining to folks. Motivational interviewing is one that is essential too. We have our wellness team here at the department developed WellPower training and wellness coach training, which is required for all the wellness coaches. Some of the lessons learned is the importance of the Health Home team meeting regularly, making decisions together as teams, and figuring out ways to integrate the doctors who are the most difficult, their time is in most demand, and to engage those primary care doctors as needed. We did build in, we really wanted a separate rate to be able to pay PCPs, even patient-centered medical homes, for the most part, when you're dealing with children, to consult with the health homes. But CMS absolutely would not go for that, and so we did build some into the rate for health homes, and so we keep reminding them, no, you actually have some funds for that. So if that's what it takes, you do what it takes to get these doctors to consult with you. A lot of them have gone in, and the doctors are used to people coming in, and so they'll take a tray of sandwiches or whatever so that they can get enough time with the doctor to actually have a meaningful discussion with them. Preparing for change, there's just never enough time and ways that you can help prepare a system, our large system, for this degree of change. And we were in a hurry. We have urgency, and so there may be times that we've pushed them up. Well, there are times I think we've pushed these providers almost to the limit of how fast they could make changes. So we've definitely at times totally overloaded them with new information, and sometimes getting into the weeds and creating a situation where maybe they temporarily lose sight of what the vision is. And so there are some links to our information and references, and we'd be glad to share any information. I just can't say enough about, there were times the first 6 months, and I might tell people maybe it's not a good idea to go statewide right away. Our providers never want to be left behind, and so when we start something, they all want to start together, and our commissioner was also very urgent that we do so, and so we jumped in with both feet. That does not mean that all health homes are created equal, and we just created a tier system for this coming year that I think is going to be absolutely great, which wouldn't have worked the first year because we just had to bring everybody into the same culture and getting the same message all year long. We developed 3 tiers, and so our upper tier that are our most highly developed and highly functioning health homes, they will be able to just run with it and be a group, a learning collaborative together, and there's just no telling what they'll do this coming year. And then we have that group at the bottom that's just kind of really struggling, that will get some really intensive just hand-holding and walking through things and targeted TA. And then the group in the middle that still needs, a kind of a different approach. And so that's our philosophy for how we'll be working with them going into this new year, this new state fiscal year, starting in July. So there's so many things. It's hard to know what all to touch on because it's so multifaceted. But that's just a little glimpse of our behavioral health homes in Oklahoma.
Thanks very much, Jackie. That was a great overview of all the work that you've been doing. And I wanted, just sort of as we're wrapping up here, point out to people that both of these states, New Jersey and Oklahoma, also have something in common in that they built on their system of care infrastructure in order to integrate health homes into that infrastructure rather than having health homes be sitting, somewhere else over there and trying to figure out how to connect with them. I think that's really important. And secondly, both of them are approaching this very much as a sort of continuous quality improvement and learning environment. And you can hear from both Liz and Jackie how they're continually talking with their health homes and others about how to make changes, what they can put in place in terms of capacity building and training, and I think that's also another really important lesson. So again, I want to thank you both. We have listed some resources in addition to the ones that Jackie provided that are Oklahoma specific. There are some additional ones both in this slide and in the next, which is the federal, this last slide here is the federal Medicaid guidance that has come out that's relevant in terms of effective approaches to think about building on. And the National Technical Assistance Network for Children's Behavioral Health is, very happy to get any questions that you may have following this webinar that we can have Oklahoma or New Jersey or myself or someone else weigh in on to help answer. So again, thank you very much, Liz Manley from New Jersey and Jackie Shipp from Oklahoma, and for all of you that may be listening into this webinar.